or take little steps. So stand, pivot, sit, transfer to the mat, transfer to the surface. Okay. So we've been going over levels of assistance, right? So we know that Min Assist is the therapist performing how much?
25.
Right, or less. And a Max Assist transfer is?
75.
And so 75% the patient does, 25%. Oh, max, yes, 75%. Yes, at 75%. If you do more than 75%, that's right. So 75 would be the most. And for the most part, that's kind of how you start to think about the transfer. And then as you get your clinical skills and you get experience, you'll be able to discern better what would be like 60%, or 35% or something like that. But for the most part, this is a quadrant, right? So I've got 25% of each. So that's how I'm going to kind of teach it to you. Okay. Supervision, right? So supervision is you're my therapist and I'm transferring on and off the mat. That's supervision. Still around for safety in case you have to cue me. Okay. If you were going to be close, you'd be right next to me, but not touching me. And if you were distant, you'd be in the hallway going, okay, I want you to transfer on and off the mat. That would be distant. We do that. I'm in the hallway and I said to the patient, okay, I want you to walk to the bathroom now and back. And I'm not in the room, so I can't see all the wonderful things that they're doing on their own. I'm hoping that they do it right. Okay? So you're going over the gait belt a bunch of times, right? Okay? I like the large ones because you can use them with a lot of different people. All right? The bariatric patients, we've actually been known to put two gait belts together, depending on how wide the person is, or by a wider gait belt. So, the big thing about the transfers and you know, doing the other two transfers, you want to get comfortable with your therapeutic voice. Say who you are, why you're here. Hi, my name is. I am going to be your occupational therapist. Do you know what occupational therapy is? And then make a nice script for yourself. So I say, hi, my name is Carrie. I'm going to be your occupational therapist today. Do you know what occupational therapy is? I usually say, I have an idea, or no. And I say, okay, well, I'm the one that's going to work with you on things that you do every day, activities of daily living, like getting dressed, going to the bathroom, washing yourself up, maybe even making yourself something to eat, IADLs, and everything that goes into that. Balance, your endurance, if you're weak in your arms, and then of course for my patients, it's every other thing too, vision, perception, cognition, etc. But for the orthopedic population, and sometimes for the orthopedic population, if they have a premorbid history of dementia, or Alzheimer's, that will come into play. But for the most part, that's what I say. Okay, so you guys want to get that because that's something that you're going to need to know for this class. All right, yep. Now get used to saying it because that's what you're going to do when you get your fillers. Okay. You want to get accustomed to explaining the transfer, what the expectation is, so the patient knows what they can do for you. They all want to do whatever you want them to do. They're just waiting for direction. So you're going to explain the transfer. Who wants to be my patient? All right, come on over. Have a seat. All righty. So the leg rests are off. Don't want the leg rests on when you're doing the transfers, right? Because they get in the way. So I just remove them. They're off.
Can I go over there in the corner on the
Sure.
Beats me.
As long as this doesn't end up on YouTube. Yeah, and Stony Brook they did that too. Okay, so I moved the wheelchair a little bit more of an angle. If you are, if you're just straight, the most you have to rotate their hips is 90 degrees. So if I can turn it a little bit more, that's less effort for me, or less the patient has to do. Better energy conservation, etc. Okay. Hi, my name is Carrie. I'm going to be your occupational therapist today. Do you know what occupational therapy is? Wow, welcome to the wonderful world of wheelchair. I'm the one that's going to help you get out of that wheelchair and onto the bed. But I do other things, like helping you get dressed, taking a shower, or washing yourself up, getting on and off of the toilet, getting out of the shower stall. But we'll do the other stuff too, like, maybe make yourself something to eat, talk about your laundry, and anything that you need equipment-wise, I'll help you out with that. Okay? Great. So what I'm going to ask you to do is just lean forward a little bit. I'm going to put this gait belt around you. It's going to be nice and tight, but you should still be able to breathe. Okay? so it should feel like a girdle around the person. And then, but you still want to get your one finger in there so they can breathe. You know, if you have somebody who has cardiac surgery, you want to be mindful of where the belt goes. You don't want it too high. If they have pegs, you have to be around that area. So what goes on with the patient is just as much as dictates where the belt goes as, you know, where we're going to teach it. But generally speaking, it should be down around the hips area because everybody can be controlled by their hips, right? Tilts. Pelvic tilt. All right, great. So what I'm going to do is I'm actually going to scoot you forward in the wheelchair because you're a little further back. Why would I do that?
Easy to get up.
Pardon?
Don't keep them.
No. Because if I have to lift her from all the way back there,
It's more
I
work for
can't
you.
squat to do that. I have to do this. So I have to get closer to her. So if I bring her forward in the wheelchair and I go to squat, squat makes my life easier. Okay, so I'm gonna move you over, move you forward, so I'm gonna kind of unweight you a little bit. Got my hand on her, I'm gonna come under her thigh and scoot her forward. All right, do this a couple times. Kind of come under here, scoot her forward. There we go. Yeah, thank you for helping. Good, that's perfect. Great. I want you to put your hands on the wheelchair, and then I'm going to help you stand up, and then I'm going to help you pivot, and I'm going to help you sit down, okay? We're going to go on 1, 2, 3. Yep, we're getting there. Now, sometimes I will use a little momentum to help lift the patient or get them in the concept of what it is that I want them to do. Nobody really, except for pregnancy, it's very rare that we stand up like this. Okay? So you want them to lean forward. That's how we normally stand up. That's what you want. So you may use that momentum strategy so they understand what you want, especially if you have some cognitive challenges or they're really doped up on medication. But for the most part, most people get how to stand up. Okay? So you are only going to help me with this thing. You have your hands on there, but you really can't push to stand up, nor can you stand up with that leg. And then I'll pivot you, so I want you to, you're going to bear weight through your left leg, and then also sit on the mat. So if she only uses that side, that part of her body, what would she make? She only uses her leg for the transfer. And I have to provide, yes, max. Because we're going to make her into a quadruped, 25, 25, 25, 25. So if she's only using one part, she's only doing 25%, I have to do 75%. Okay? Okay. So you want to get nice, crouch, stick your butt out, get used to it, it's okay. All right. So we're gonna rock, and then we're gonna stand. 1, 2, 3. Don't help at it, girl. Turn, stick your butt out, and sit. Very nice job. Good job. What did I do? When I put my hand on her scapula. Because why?
I didn't realize that.
Why did I do it? Anybody?
I didn't even see it.
No, because actually where she was when I pivoted her, I felt she was a little shallow on the back mat. So I was afraid if I sat her down, she'd be too far at the edge. So if I stick her butt out, I have a better chance of her sitting further back on the mat.
So you push her back.
I push her forward, makes her rear end stick out, she gets deeper in the chair, right? Okay. Even though I'm going to have to scoot her forward again, you want her to always be safe. So it's better for me to have to do the work than for her to fall. Okay? So that was max. So she really wasn't helping me. I really did most of it. Stand her up. What? Correct. So stand up, pivot, and then I sit. Now most therapists, etc., they've been out in the field, they do that a lot faster. You want to do it slowly because you want to get accustomed to controlling the patient and the environment.